Today's webinar is called Critical Incident Presentation for Healthcare Interpreters, Interpreter Rounds. And I want to thank the participants of my presentation with a similar title at the only in-person conference this year, which happened in San Diego with California Healthcare Interpreters Association, because they helped me develop this presentation further and gave me suggestions on how we can at CCHI turn it into a consistent national program. I want to dive right into the subject of this presentation, but for those of you who don't know me, my name is Natalia Mitareva. I'm the Executive Director of CCHI, but I was one of the founding commissioners by training. I'm an interpreter, translator, and interpreter trainer. So I've managed interpreting services of a refugee resettlement agency for 13 years prior to working for CCHI. And at CCHI, one of my tasks is to participate in continuous test development. And as you know, in our tests, especially in the CoreCHI test, we have scenarios where we ask questions and about which we ask questions. And so these are those critical incidents that our test knowledge of which is tested at our exam. So I have a vested interest in this topic, and it's a very interesting topic for many of us who have been in the field for a while, but really the learning part is intended, of course, for beginner interpreters. I will see it. So, how will we work today? First, we will talk about healthcare rounds and interpreter rounds. What do we mean by those concepts? Then we'll define what a critical incident is in the context of healthcare interpreting and see how we can classify them. Then we'll think about the reasons for these incidents, why they occur, how can we turn them into a learning moment. Discuss the elements of the critical incident report, because if we want to turn the incident into a learning moment, we really need to make sure that we are presenting them, reporting them, somehow documenting them. And then I will give you an example of a critical incident report. We'll try to just together improve it. And at the end, we'll talk about what we should do moving forward. We'll talk about the repository for the reports and the virtual interpreter rounds. So before I start talking more, I want to ask you a question via poll. So if you're on an app or on a desktop, you will see this question pop up in a second. And I want you to select the correct answer. It's a multiple choice. So the definition that is given on the screen applies to which of the following? Grand rounds, rounds, or Schwartz rounds. And the definition is daily visit by the attending physician and team to all of that physician's patients on the ward. What is it? Is it rounds, grand rounds, or Schwartz rounds? Of course, staff interpreters, or interpreters who in general often work in hospitals, or managers of interpreters, have an easier time answering this question. So let me give you a couple of more seconds. So don't worry if you get it wrong. All right, it's a new term for many. So let me close this poll and share it with everybody. So 21% considers this to be grand rounds. 76% got their answer correct, rounds. So when we're talking about the daily visits of all the patients by a physician and whoever is assigned to him as a teaching learning team, that's the rounds. And then 2% thought it was Schwartz rounds. All right. let's go to the next question. Again, there will be a definition, and I need you to choose the correct answer for that one. And the definition is presenting the medical problems and treatment of a particular patient to an audience of doctors, residents, and medical students. Is it grand rounds or is it Schwartz rounds? As with all multiple choice questions, it's important to not read more into the question than what it has, right? So, all right, great. Let me share this with everyone. So majority got the correct answer. It's grand rounds, and 72% of you answered this correctly. So now that I have an idea of how familiar you are with the concepts, let's get to the presentation, and let's talk about all these definitions and see how we can pick the one that will best fit interpreters. So, to repeat, daily visit by the attending physician and his team or her team to all the patients is rounds. Presenting a methodology of medical education and inpatient care, which consists of presenting medical problems and treatment of a particular patient to an audience of doctors, residents, and medical students, is grand rounds. And then Schwartz rounds, I know some of you were wondering what's Schwartz rounds. It's a multidisciplinary panel sharing their experience about a case or a theme related to the emotional impact of patient care that care team members experience. So Schwartz rounds are not clinicalness they could have clinical components, but the focus is more of the emotional impact. And also it is a multidisciplinary panel that reviews a specific case versus with grand rounds, we may have multidisciplinary in terms of specialties, but with the Schwartz rounds, you will involve caseworkers, social workers, and other staff at the hospital, not just nurses and doctors. If we, judging by these definitions, it is clear that the healthcare as a system has thought about the importance of discussing the care of a patient and specific cases that emerge with peers, and they thought through the system that would allow these discussions to be fruitful. And because we are part of healthcare delivery, interpreters are essential healthcare workers as any other member of the team. We need to be familiar with this, but for us the most important concept is how can we model something that doctors and medical students and residents and nurses do with the grand rounds for ourselves? How can we learn from the incidents that impact communication and interpreting, and how can we establish a system where we will be able to use this as a learning moment? If you look at websites of different hospitals, just if you search there on their websites for grand rounds, you'll find different schedule events. I think this one belongs to Stanford, and here you can see that the topic for grand rounds in medicine was burnout, shame, vulnerability, and resilience, practicing primordial prevention, or searching for the cause of type 2 diabetes and the metabolic syndrome, right? So there's the topics are very complex. Now, another example here on the right is from Cincinnati Children's, and you can see that there are different subgroups of grand rounds here by specialty. And then if you click on each of these bars, you will see different other topics. And these are online courses that doctors, nurses could attend and learn. So that elaborate system shows how important it is for our colleagues who are clinicians and allied professions to learn about providing healthcare to patients. And we interpreters should strive to be as close to other healthcare professions as possible. That's why we feel that it's important to have a similar structure, a similar mechanism for all of us to discuss interesting cases that pertain to interpreting, because rounds is an opportunity for reflection, for understanding the situation better, and because they involve several steps: presenting that case and then discussion of this case. This reflection is not only self-reflection, but it is peer guided conversation that could produce the solution that one person may not have come up with, or one person could come up with one solution, but as a group we may find a more elegant, more efficient solution to that incident or problem. So to define interpreter rounds as a concept, this is the working definition for us. Interpreter rounds is presenting to and discussing with an audience of interpreters and language service managers. Because remember, if we need to do something, we usually escalate to our managers, so we need to include them in these rounds. Situations that posed either linguistic or ethics-related challenges to the interpreter. In other words, we're not going to discuss anything about did the doctor did the treatment right, was the patient satisfied. That's not what we're about, right? We're focusing on situations that either challenged us as from linguistic perspective, we couldn't find an equivalent or there is no equivalent yet, or we did something and we're not sure if we overstepped our role boundaries. Also, as part of that presenting and discussion, we'll be looking at the possible solutions to those challenges and recommendations for further actions at a profession-wide level if needed. Suggestions for research, establishing new standards, editing some standards, because as we know, we have the Code of Ethics, Standards of Practice, but those are, first of all, very succinct documents. They are very short. They cannot cover every possible situation, and they're just the guidelines. So we need further documentation to help, especially new interpreters, to enter the profession and do things right from the first time. So why is it important in general to conduct this type of activity? Well, reflection is an effective self-learning and teaching tool for professional growth. There, as many of you I know here are trainers, you know that as trainers we sometimes learn the topic the best when we're first presented, right? So because we've had this self-learning and self-reflection after we delivered it, after we did it, and that's what improves our training. And the same thing for interpreters. When we act in the moment and do our job, we sometimes leave the room with that gut feeling like, it was not my best performance today, right? And that's usually where we end. But if we reflect on why did we get that gut feeling, we could learn from that moment. On personal level, reflection on anything, but specifically in the context of interpreting, helps you better understand your strengths and weaknesses. It helps you identify and question your underlying values and beliefs. And that's very important because as healthcare professionals, we also get training in cultural competence. Because we speak two languages at least, and come from or interact closely with at least two cultures, we think we know it all, and that we think that we're open and all our values and beliefs are very accepting and etc. But then there are moments when we are faced with situation when we discover that, well, we're open to a certain point, and at a certain point, something prevents us from being as neutral as we should be. So it's important to know that values and beliefs, first of all, they are, the core of our being, but they also evolve, and they are also tested in juxtaposition with other values and beliefs. And so you may be uncomfortable, not because you're wrong, but it's because your values are questioned in a different way in that situation. So reflection helps you understand that. It also helps you acknowledge and challenge possible assumptions on which you base your ideas, feelings, and actions. If you get yourself a moment to think like, well, they didn't say it because they were blah, 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 but maybe there were other reasons why something was not said. We also, when we reflect on a past occurrence or past incident, we recognize areas of potential bias and discrimination. And we all, as a country, as the humanity, are now grappling with this, resurgence of awareness about racism and discrimination. And the easiest thing to say is, I'm not a racist. I know that, right? But reflecting about specific situations, that's what will really, help you fully understand yourself and act accordingly. It also helps you acknowledge your fears. I'm very grateful that I was asked to interpret when I started my career in this country, to interpret for a domestic violence court case, because right there I faced my fear, and my fear was that I cannot be objective to an abuser. I simply cannot. You can do whatever you want to me. I cannot be objective, and I cannot interpret the words of an abuser in a neutral, faithful manner, because it just goes against my grain. And for that reason, when I discovered that fear of being not neutral and not providing a good service to an abuser in a situation, that made my decision, helped me make the decision to never go to interpret back to court. And that's what I did. I switched fully to medical interpreting after that. And here I do avoid, I have avoided, I don't interpret now actively, but I have avoided interpreting for situations when abusers are getting, treatment, support groups and anger management classes. I'm just not a good fit for that type of situation. So facing your fears and acknowledging your fears helps you understand where you need to recuse yourself as an interpreter. It also helps you identify possible inadequacies and areas of improvement. And my inadequacy, I can tell you, is numbers. I do not trust myself with numbers, interpreting whenever they start discussing different dosages of medication, how let's adjust this one for this and this one for that. I write down all the numbers, because otherwise I know I cannot repeat, even if it's simple as 2 and 3, and it will be 4 and 5. I will not repeat it. So I know my inadequacies because I reflected on them. And that's an important realization, because after you do it like 3 or 4 times, you understand that it's not because you're not paying attention. It's just because something in your brain doesn't help you remember the numbers. On a professional wide level, reflection helps us all. And that's why we want at CCHI to have it as a continuous, consistent project, not a one-time webinar, because it helps us identify peer-reviewed acceptable solutions and strategies that would better detect, manage, and prevent problems. Because we want to make sure that we as a profession identify these incidents where there is a potential for error, and we will alert new interpreters, novice interpreters, to those problems and situations. It will also and as a result, we'll provide the mechanism of support for new interpreters. We'll also need to identify gaps in our publications and training programs. And we can identify that if we see, like, for example, the first 10 critical incidents report, if they all will match one specific topic, that means that we did not teach that topic well enough in our programs. And we will have a database of incidents in healthcare interpreting that could be further used for research and reference. And last and not least, through going through the process of interpreter rounds, we could prepare ourselves to participation in Schwartz rounds at your own institutions, because I know the Schwartz rounds at different hospitals hold different types of subjects, but I think it is important that interpreters will propose a topic that involves communication with a patient who needed an interpreter and present that topic from our perspective, so that all our team members, doctors, nurses, other allied professionals will understand that we are equal in analyzing and assessing care that is delivered to a patient. And so just that adding that our voice at that level, it's both institutional level and research level or medical education level, is important, because we as a profession need to continuously be visible to other professionals in healthcare. Now, let's look at another definition, and let's start with the word that I've been using, the term I've been using, critical incident. Well, as with all terms, there is one meaning and another meaning, right? So there's broad meaning and narrow meaning. Critical incident in a broad sense means something that happens either positively or negatively that makes you stop and think, or something that raises questions for you. That's the broadest meaning, and that's the meaning it's used in different industry. Now, in healthcare, critical incident is a term of art. It's a specific medical term, and there it means any unintended event that occurs when a patient receives treatment in the hospital that results in death or serious disability, injury, or harm to the patient, and that does not result primarily from the patient's underlying medical condition or from a known risk inherent in providing the treatment. So here, as you can see, the meaning is a little narrow. It's critical incident that reached the patient, and it's unintended, and the result is death or serious disability, injury, or harm. So that's the difference between, general and specific understanding of the word term critical incident. When we as interpreters will select incident for our interpreter rounds, we need to make sure that we're selecting them from the perspective of the interpreter, not the doctor or any other care team member. And for that reason, we need to make sure that that incident that we are preparing to discuss relates to communication in general or specifically to interpreting. Because again, we are experts in communication of people who speak different languages, right? So both relate to us, interpreting and communication issues as well. Now, it also should be an incident where you personally were involved. And this is kind of like the part of me telling you what we would like to see in those critical incident reports that CCHI would like to provide a repository for. So it's an incident where you were personally involved as an interpreter. If you're a manager, as a manager, meaning that you may not have been present during the incident, but the interpreter came to you and related to you, and you had to provide guidance. So it still is you are involved, but do not write incidents which you heard from a friend, because you won't know all the details. And also don't make up, don't simplify or make it more complex. Don't come up with something. I know it'll be tempting, but don't do that, because we truly want to have the real incidents, catalog real incidents, not made up stories. It also needs to be an incident about which you feel either very satisfied that you found an optimal solution. It's something like, oh man, was I good. I did it so well. I mean, I can't believe I interpreted so well. So that's an incident to report, because again, it's negative or positive. I understand we'll see probably more negative impacting incidents than positive ones, but positive ones are also very important for us, especially if they deal with linguistic findings for, let's say, new terminology or interpreting of new terminology. Then it can also be an incident where you feel doubt, frustration, or anxiety. And here it'll be, man, it just didn't work for me today. Could not do a single thing right. Had to correct myself all over and over again. So that's also something to report, because the more experienced we get, hopefully, the less often we will see these kind of reactions for ourselves. And so those definitely will be the moment for reflection. Why? I mean, you've interpreted for 20 years, you're certified. Why did it happen? Right? So it'll be interesting to find out and to reflect on it. And as a community, we can help identify that moment. And it could be that you found some flaw in our system that we need to fix. In our system, I mean, code of ethics, standard of practice. So, or in the facilities protocols that you are interpreting for, there may be some steps missing that would prevent you from being successful. And also, it could be an incident that would about which you'll feel that burning desire to change the existing protocols of practice. And I know they will occur because, again, the standards of practice of code of ethics are very broad documents. They are not meant to catalog all possible incidents. Before we dive further, how do we write the report about these incidents? Let's just first analyze them a little bit, think of how we can classify them. Because when something occurs, if you put a label on it, classify it somehow, it makes it more manageable and easier to think, right? But it also sometimes could mean that you labeled it one way, and then when peers reviewed it and said, no, that's wrong, that's not what it is all about, that's why you were making a mistake, you mislabeled it in your classification. So let's talk a couple of minutes about types of critical incidents. So we can classify them in relation to interpreting as a skill, as a role, and of course it starts with incident could happen because of the misunderstanding of the healthcare interpreter's role. Whenever I hear somebody said, well, I wanted to help the patient, that kind of is like, okay, do you realize where your role boundaries are? Do you know that you're not the one who is going to actually prescribe that medication, and you're not going to be standing and watching them taking that medication? So you're not going to save the patient, but your role is to relay the information accurately in a culturally appropriate manner and manage so that both sides understood what they tried to relate to each other. So that misunderstanding of the role is cause of many mistakes on actual certification exams, when interpreters, instead of interpreting what they hear, interpret what they think should have been said. That's again misunderstanding of your role, because we don't put words in people's mouth, we just interpret them. Another area where there are a lot of incidents occur, especially, if you're a novice interpreter and inexperienced, the more you do it, the better, and the more you continue your professional education, the more you learn, but still the demands of the healthcare interpreter code of ethics. And it's especially tricky for healthcare interpreters, I must say, because we have competing standards of, let's say, impartiality, confidentiality, and advocacy, right? There are situations when all these three are in conflict, and you have to get a professional judgment of which one takes precedence, which one should be applied in this case, and why in a very similar case, the other one will be more important than the other, any of the other two. So, and it's, because we're dealing not with binary codes that computer people deal with. We're dealing with human lives. And in healthcare, we're dealing not just with the body, we're dealing with the minds, we're dealing with the psychic, we're dealing with relationships. We have so many situations that it's natural to have those incidents and those demands of the code of ethics being unmet or being misconstrued. Another type of incident will be when the actual core of the problem was the cultural awareness. challenges. And that, again, culture is a very complex construct, and you cannot learn it once and for all. You know, it's a continuum, and it's continuum on all these three, for all these three participants in the interpreting encounter. So this definite, and it's a clash sometimes. So that's why there will be incidents that mostly are rooted in the challenges of cultural awareness. Then linguistic challenges of meaning conversions. Those usually stem from the fact that for some interpreters, there is a clear dominant language and a clear weak language. So whenever you do the interpreting into the weak language or from the weak language, you will have those challenges of keeping accuracy and keeping meaning. And of course, that will create different kinds of incidents and dissatisfaction, feelings of dissatisfaction. At the same time, that will also be an opportunity of feelings of high exhilaration when you find the right term. And then last but not least, demands of skills of interpreting per se. In other words, your mastery of consecutive simultaneous site translation modes, your mastery of the task of comprehension in two languages, of handling the remote interpreting software and hardware things. So that also could be, there could be incidents that are rooted in the understanding of our skills. And so in addition to classifying our incidents by their relation to interpreting, we can also classify them by the criticality. In other words, what impact that incident, that occurrence had on the patient or the provider, but mostly, of course, on the patient. So we propose to adopt the classification that doctors use. In other words, criticality to the patient. While we, of course, understand that we're also affecting the doctors and nurses when we interpret for them as much as we interpret for our patients. But when we, the impact of our errors for doctors could be, loss of reputation, practice lawsuits, having to do more tests, but they would not result in the death of a doctor, right? So, a nurse. So in that respect, the criticality is important when it relates to the patient. So we start with the incidents that we can describe as notable or reportable circumstance. A situation in which there was a significant potential for harm, but no incident occurred. In other words, a moment where you felt uneasy and you said, oh, if I have not caught this could have happened. And the reason this could have happened because of X, Y, Z. That's what that reportable circumstance, and we need to fix it, right? Near miss. That's a level of criticality of an incident when it almost happened but still didn't happen. Again, the situation could have happened, resulted in an accident, injury, or illness, but it did not, either by chance or through timely intervention. That's still something to help us understand of how we can avoid even near misses, because with one interpreter it was a near miss, with another one it would be harm, right? Then no harm incident. In other words, the event occurred and it reached the patient, but no harm was evident. That's a opportunity for us again to improve ourselves, because we ultimately don't want to cause any harm, right? So I would hope that most of our incidents that we as a profession will identify by 10 years from now, have some great researcher analyze all these critical incident reports that we'll submit, and we'll discover that most of those are no harm incidents. That will be lovely. But the other levels of criticality actually result in harm. And here there are several classifications. I'm trying to be as granular as possible so we can distinguish this importance of our actions better. Mild harm. Loss of function or harm is minimal or intermediate but short term, and no or minimal intervention is required. To give you an example, if, for example, you interpret it for the patient and they come back 2 days from now and they explain to their doctor, yeah, doctor, I've been taking 2 ibuprofens for 2 days and this happened. And the doctor looks and says, oh, you should have been taking 1 ibuprofen. And so the interpreter misinterpreted the words, let's say, in this situation. Instead of 2, said 1, but it was caught in time. Yes, there possibly was mild harm to their stomach lining of using ibuprofen higher dose than before, but it really doesn't need any intervention. Everything ended well. Now, if you would say, if you double the dose, let's say for insulin, then that patient may end up with moderate harm, and they may have to go to emergency room, and because that event results in an increased length of stay or increased level of care, or causing permanent or long-term harm or loss of function. So that increased level of care, having to go to emergency room, that would be a moderate harm if in interpreting. Severe harm is permanent lessening of bodily function not related to the natural course of the patient illness or underlying condition. And hopefully we'll never misinterpret or do something that will cause patients severe harm, but at the same time, let's be realistic, we're all only human, this may happen. And then the last possible level of criticality is death of a patient. So one of the distinctive characteristics of healthcare is that in addition to these levels of criticality, healthcare and the other industry that's comparable to it is aviation, created special policies that address of how healthcare providers should address this incident. And that's why aviation and healthcare are considered the 2 best industry that address different incidents. In our case, in the healthcare system, the Joint Commission has Sentinel event policy. And if you are not familiar with it, do the Google search for Sentinel event policy, and the first link comes up is for Joint Commission. And a Sentinel event is defined as a patient safety event that reaches a patient and results in any of the following: death, permanent harm, severe temporary harm, and intervention required to sustain life. And such events are called Sentinel because they signal the need for immediate investigation and response. So in our case, if we identify that there are some gaps that may result in an interpreter causing a Sentinel event, we definitely need to know that as a profession and see how we can address those gaps. I think we are successful as preventing them through our training, but it's our gut feeling that we're successful, right? But we need to make sure that we truly do not contribute to Sentinel events, or if they do occur through our errors, we know how to improve and handle them. So why do incidents occur? Now, it's all great to classify, right? But why do they occur? Because we're human, right? I'm going, before we go further, let's just do some fun exercise here. I'll show you a picture where there'll be a list of words. Do not read the word. Instead, say the color of the word. Okay, and just do it for a couple of seconds. Okay, so if I will do it, this is how it'll sound. Green, red, purple, yellow, red, purple, black, yellow, red. You see, I can read, right? I proved it. I just read for you for all these minutes of things from the slide. And I know colors in English. So, but why is it still so hard to do what I said? Say the color instead of reading the rule. Why? Any ideas, guys? Type in your question box. Why is it so hard for us to do this? I know it's also, late on the East Coast, but other than that. Multitasking. Yep, the brains revert back to reading. We assume, exactly, we assume that if it is a text, we're supposed to read it, right? And then our brains are trained to perform these things. It's a sort of code switching. Exactly, when you code switching between, let's say, English and Spanish, so all these things that occur, and that's a natural, and that's why, even simple things, supposedly, could cause us to mistakes. We're in conflict with ourselves. And that's why since we are human beings, thank God, we need to acknowledge that regardless of our experience, intelligence, motivation, or vigilance, and the fact that I already selected that slide for you, right? I presented this presentation already one time, and I still started stumbling, by the sixth word? That means that all of that doesn't matter. We all make mistakes. A definition of what a mistake or an error is when someone is trying to do the right thing, but actually does the wrong thing. That's what an error is, because we don't plan to make them, right? We're not committing an act of, adversary act. We are trying to do the right thing, the good thing, but something wrong happens. And that's why it's important to recognize that, and to be gentle to yourself, and not really be angry with yourself while you made a mistake. You just need to really try to figure out why that mistake occurred. Human errors occur because of failure of one of the two types. It could be a skill-based error. In other words, an action does not go as intended, an error of execution. And knowledge-based mistake. So this, you see how error and mistake here, different words meaning the same thing pretty much. But knowledge-based mistake is the intended action is the wrong one, a failure of planning. So when you don't know what to do and you do something, it happens to be wrong, because there's 50-50 chance when you don't know, right, whether it will be right. That's your knowledge-based mistake. But if you have an error of execution, that's your action just didn't go as intended. Now, the skill-based errors could be of two types. One is slip of action. In other words, the action is observable, but it's incorrect one. For example, on Zoom meeting, you're all on mute, and then somebody asks you a question and you start talking and you forgot to unmute yourself, right? We all know that. So that's your slip of action. If you're a remote interpreter, for some time you muted yourself, then you again forgot to unmute and started interpreting, that's your slip of action. And memory lapse. You didn't do it. The action didn't even happen. For a nurse, for example, it will be not giving a medication, forgetting to give the medication at a certain time. For an interpreter, a memory lapse could be forgetting, well, you see, I'm showing you a memory lapse, right? Forgetting what I'm supposed to say next. It didn't even reach you what I was supposed to tell you. But you saw my error of my mistake, this with connection with this webinar, right? Yesterday, a day before the webinar, you received an email with the wrong subject line. It's because I forgot to change, and that will be a memory lapse. I forgot to change the subject of the previous webinar in the reminder email. And then I was reminded by one of you, and for the 1 hour reminder of this webinar, you got the correct email. So that was a memory lapse. Now, mistakes, remember, knowledge-based, they could be rule-based or knowledge-based, again, further down. They are the error of planning, and the rule-based mistakes happen when you incorrectly apply a good rule. You didn't read the situation right. You got the good rule, but didn't apply it correctly. Application of a bad rule, that's something which we are really, as a professional, interested in. finding a bad rule for a certain situation so we can say, oh, don't do that, because it's really not even a violation of error. It's identifying the weakness. A failure to apply a good rule. That's what the majority of novice interpreters' errors related to ethics are. They are failure. They know the rules in their at their knowledge level, but they're not yet at the execution level, and they just don't apply the good rules. And failure to apply a good rule is also known as a violation. Now, there should be distinction between when a violation is an error and when a violation is a planned action. So in general, violation, if we define that word, is a deliberate deviation from an accepted protocol. And they become errors when the intended action results in unanticipated adverse consequences. In other words, you didn't mean it. You tried to do the right thing, but you didn't know better. But if you planned to do the bad thing and that succeeded, then it's already not a human error. This is a violation that requires a disciplinary action and formal investigation. So, I am assuming that all of us are dealing with mistakes, not with planned violations. Now, the violation as a mistake, as an error, could be routine when, for example, we are told not to put certain things in the fire exit, near fire exit, and we still put a chair near fire exit that blocks the fire exit. And everybody is doing it, and then we remember when the inspector comes and we move that chair out. So it's routine violation. It's not good, but it's, something needs to happen so that in the system level to avoid that, to prevent that. Situational violation occurs when, in response to some situational factors, we decide that applying the usual rule is no longer safe, or if we apply it, we won't achieve the desired outcome. That's thinking on your feet, deciding that there's more harm in applying some rule than in not applying it because of this once-off situation. And then exceptional violation, when it's a rare occurrence and it happens in abnormal circumstances, and we all lived through those abnormal circumstances this March and April, when the COVID disrupted a lot of healthcare delivery patterns and our work. So I'm sure there were violations of many different rules there because it was new and it was a very systemic disruption of the whole care delivery. Now, violation of a bad rule, as I said, mentioned earlier, is not actually an error because this is the discovery of the situation when the rule should be changed and the procedure should be changed. So we hope that we will see these critical incident reports that will address some of the bad rules either at the local facility level or maybe even at our profession-wide level. So now that we've analyzed and defined a critical incident, I hope it's kind of clear in your mind what a critical incident is and what we're looking for, what is the reason for looking for those critical incidents. Let's think of how we can turn it into a learning moment, because after it occurs, we will be thinking about either consciously or subconsciously. So let's think about it consciously so we can find the root of the error, why this occurred, and how we can prevent this from happening in the future. There are several, at least 3 types of risks or factors that could increase the risk of this kind of incidents: personal, organizational, and profession-wide. So personal, limited knowledge of healthcare interpreting in general, right? Especially if you are either switching from, let's say, business interpreting, conference interpreting, court interpreting to healthcare interpreting, the differences that you may not be aware of, or limited knowledge because of your lack of experience. Limited healthcare interpreter skills. You know the ethics, you know the role of the interpreter, but you really, some of your skills, let's say site translation, is not very strong. unfamiliar environment and protocol. If you worked all until COVID-19 pandemic, if you worked as a face-to-face interpreter only, and then you was switched overnight to remote interpreter, there are definitely opportunities for errors there, because you have never done it before that way. Distraction and inattention, and this could happen to all of us, right? Fatigue, the last appointment, or like this webinar, I probably sound more tired than if I did it at like 11 o'clock. Stress, hunger, illness. We're human beings. We need to be fed. If we're hungry, if we need to go to the bathroom, and we cannot focus on interpreting, I'm sorry. And these personal factors will create the opportunity for more errors than if you're removing them. Organizational factors, inadequate information. If you're a freelancer coming to a hospital environment, let's say a freelancer who never did it is coming also to a psychiatric ward, right? In addition to your unfamiliarity, you also don't have an adequate information because they didn't tell you it'll be a psychic ward. They just told you, here's your appointment at 3 o'clock. Poor procedures. In other words, an organization does not have procedures of how the interpreters could relay information to supervisors, how they could, connect, and who they can connect with to get support they need. Poor staff training. Time pressures. Those are the time pressures number one. If all hospitals hired enough interpreters for every appointment and for every patient, then we wouldn't have to run between appointments like chickens with their heads cut off. Insufficient staff is pretty much the same thing with time pressure. And inadequate supervision. It is important, especially for staff interpreters, to know that there is different levels of supervision and that they have somebody who will observe them and give them feedback. And if that is not happening, then they cannot grow professionally. Then the profession-wide level, we have factors as absence or poorly defined protocols and policies for some situation, inadequate dissemination of information, because I know about this inadequate dissemination because we have candidates that keep asking us and sometimes even certified interpreters about renewal procedures, same things that are all explained on our website and in our publications, but we didn't convey well enough where to find that information. And of course, the same thing happens to the code of ethics and standards of practice and availability of trainings on specific subjects. So we need as a profession to do better. Failure of enforcing protocols. We, again, do not have a disciplinary board. As an organization, CCHI does have disciplinary policy towards certified interpreters, but I'm sure in the United States there are more than 4,500 interpreters who are certified, right? So who is applying any disciplinary actions to them? And even with our disciplinary policy, while we do get complaints, we don't get as many as probably occur. So we need, again, as a profession, to think about the potential mechanism of enforcing the existing protocols. What are the conditions for us to learn through reflection? Well, first of all, you need to prepare yourself. You need to go into each new appointment with a thought. So when if you are connecting remotely, this is when you unmute yourself. Your thought will be, okay, what am I going to learn today? I know it sounds maybe overly enthusiastic about it, but it's true that you need to give your brain the permission to learn something new. Otherwise, you will be too focused, on other things, and you will miss opportunities for learning. So that mental preparation is important. Understanding, you need to know the goals and expectations of reflecting. If you want to grow as a person, as an interpreter, you need to understand that in order for you to do so, you need to monitor your output, identify your errors and mistakes, and reflect on them. And that happens every day, every appointment, right? But understanding that why you need to do that is important so that you grow. Time to stop and think. That one is the hardest, I admit. And if you're a face-to-face interpreter, you can do it when you exit the room and you gel out or wash your hands, right? If you are a remote interpreter, that will be your time when between the calls you go to the restroom and wash your hands or take a drink of water. That's the moment to say like, okay, quickly, no, that's not worth reflecting, moving on to waiting for the next appointment, next learning opportunity. Or no, you know what, I need to remember at the end of the day to write down this specific moment. And if you kind of keep that, it doesn't need to be, it could be 20 seconds really of reflection. It could be 5 seconds. But if you give yourself that structure that you are stopping after each appointment to think, is there anything here that I can document as, important, then keep that in your journal. A level of objectivity about yourself and the impact of your actions. I know I'm the best, and I know each one of you are the best, but we also need to understand that, for some other person, I may not be so correct all the time, so perfect. So in other words, we need to take ourselves with a grain of salt, and we need to be able to step out and observe our own actions. And it's easier for us to do, interpreters, because we're all about stepping out, right? We're interpreting from one world to the other world. We're monitoring what we're saying to catch our mistakes. When we catch mistakes, we correct them. So we already have that, our brain trained for that observer role, so we just need to apply it to these kind of situations and not just to the linguistic challenges of interpreting. Honesty. That one is the hardest. I said time is the hardest. No, honesty is the hardest, because there's this fine balance between being happy with yourself, loving yourself, caring for yourself, and being honest with yourself. And when I'm honest with myself, I know exactly what is wrong, and I just then need to, it doesn't feel very, it doesn't feel very good in the moment when you have to tell yourself a hard truth. But again, if you don't do it, then you'll never progress and develop. An open and non-defensive attitude towards experience. Again, nobody's trying to catch your errors, and you are not trying to catch the errors. You're trying to find an opportunities to grow, to learn. And focus on the deeper level of meaning, moral, ethical, societal, professional issues, and additional to your own emotional response. That always helps, You may think like, oh, I'm just so mad, so frustrated, and then start thinking, all right, let me just forget being mad for a second. What are the implications? Did I do harm to the patient? Okay, no, it seems I didn't do any harm. So then you kind of cool yourself through this level of reflection you're trying to. So you need to always be, kind of aware of all these conditions that you need in order to learn. And if you're not willing to open yourself up to these conditions, then you will not learn. You'll be just documenting things that occurred, and would still be grateful if you share them with us, but you personally won't learn really from them. And now we're getting to the rating part. That's the fun part of being creators. We interpreters usually are not creators, right? We just repeat other people's words. This is our opportunity to be a star, to create something, to be authors of the speech and not deliverers of it. So how do we create a critical incident report? Well, there are 5 steps. We describe the situation, explain it, including to ourselves, compare it to what the others say about similar situations, reflect on whether we have found enough to compare to, whether what we found matches what actually occurred, and then implicate, in other words, recommend for others that what needs to be done, or for yourself. It all depends. So these are the 5 steps, and these steps are taken from the training for medical students on how to write critical incident reports for medical professions. So I'm not pulling it from firefighters who have similar things to, or from aviation. I'm adapting what the medical professionals do to our situation. So let's go step by step. I won't stop at this little list, right? So describe incident. It's important it's really a true skill of a writer and a self-reflective person to create a good critical incident report, because you need to write it in detail. You need to choose a true situation. Don't add something to it, because the true situation is complex enough. Be very specific. If you give a general thing like, well, the patient didn't want to share something with the doctor and I shared it for them. Well, I can tell you were wrong. Did you learn anything? Right? So you need to be specific of describing what kind of situation it was, why you shared, etc. Because I know you were trained not to share information if the patient doesn't want to share it. You know better, but you did. Why did you do it? There was something in that situation that you're not telling me that forced you to do it in that moment. At the same time, there is a balance, because you need to only give as much information that is necessary to resolve your specific dilemma. Like, you wouldn't care about everything. You shouldn't be like my mom. I asked her a question on Sunday on our call, and it was a question, something about now, right? And she started in 1961. When blah, blah, blah. I said, Mom, no, that's not what I want to do. No. And so 40 minutes later, she answered my question. So when you're writing your critical incidents reports, even though I say we're a writer, but I don't expect a Tolstoy or Dostoevsky from you, I'm fine if you will be Hemingway with, all this good subtext and being concise. But so that there is a balance between specificity and what's necessary. Describe the context. Because if you will just say, and I didn't know what to do, who the heck are you? Are you an interpreter with 20 years of experience, or did you start your job yesterday? Are you a Spanish interpreter who sees 10 patients a day, or are you a my interpreter who sees 1 patient a month, right? So all these other things. Are you a freelancer, etc.? So I need to know some things for you if during that situation I discover that, without knowing who you are, I cannot give you an advice. And since we're preparing these critical incidents reports for the peer reviews through the national mechanism, you need to give a little bit more of context. What kind of appointment? Is it the first time you had this appointment with the patient, or is it your 10th appointment with this patient? So all these things could be an important context. Describe the actual incident, and then briefly say, this happened, this happened, this happened. Now, then you need to, as part of the description still, to identify the interpreting problem of what was it that made it an interpreting problem, not a social worker problem, not a provider problem. You also need to share your thoughts and assumptions, because when you're presenting the critical incident, you're showing us, this is what I did and why, right? I thought at that moment that blah, 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 and for that reason I did this. And then you need to describe the feelings that you had during and after the incident, because in addition to thoughts, because we're human beings, we also have feelings. And it felt weird. And then when I came home, I thought more about it, and I started feeling dissatisfied with myself. So in other words, we need to know a little bit more about why it is that important for you to share this situation with us. And then describe what you did with the connection with that incident, went to your supervisor, etc. Also try to reflect on, again, higher plane, on a philosophical level, what it meant to you since that time. Maybe you discovered that because of all this, you think it's important for others to know that this is possible, and that's the way to resolve it. So that's the description part. Now, after that, you need to explain. And what you explain is, why is it critical to you? Like, 20 years, this is the first time I see it. Yeah, that's why it's critical. What are you considering? What do you consider to be the most demanding aspect part of it? What is it that actually triggered your desire to sit down and write that incident report? How it relates to the interpreter profession, that, matrix I showed you, where does it fit? Is it the role? Is it the ethics? Or is it the culture? So which one of it is it? So you're explaining to us so we can start thinking of the possible recommendations. Identify the criticality level. In other words, like, well, it's no harm, but it's good to know what to do next time. Then compare the incident to existing information. Now, the good thing for us and the bad thing for us is that we don't have that many publications in our profession. If you're a doctor and you need to compare the incident to the existing information, you'll be spending hours reading different monographs, reports, and clinical presentations about certain cases to see if you find the answer. Now, with healthcare interpreting, we have standards of practice, codes of ethics, a couple of textbooks, and your local facility protocols, if as an employee you were given an employee handbook or anything like that. And of course your business associate agreement, your HIPAA agreement. So you may read that one for some situations. So there are some documents, but they are unfortunately not exhaustive, but fortunately for us, right? Not that much time. And then it's important that when you read them, you find specific passages that either confirm your action, give you more background to justify your action, or say like, oops, you didn't do the right thing. And actually those documents show you the error of your ways. Then reflection part. So why do I view it like that? Is there another interpretation for that situation? Identify the contributing factors that made this a critical event instead of a regular job performance. Assess how preventable that incident is. Identify what factors minimized or aggravated that whole situation. Like, well, if it were the first appointment of the day, it would have been great. But because it was the last appointment and everybody was running late and I needed to go to feed my child, all that contributed to this, right? So all these factors are important to spell out and try to find the lessons learned, the root causes that the system has possibly that resulted in that incident. Also, reflection is no good if you just reflect and try not to do some conclusions. So try to formulate possible risk reduction actions, what needs to change. And when you do the proposal, think how acceptable those action plans will be. If you will, your action plan will be like the supervisor needs to watch every interpreter interpreting, that's not going to happen, right? So you need to, as soon as you pray, okay, ideally this will be it. But since that's not possible, we need to do something else. I don't know what, let's all think together. That's a good already enough reflection. And then implicate, meaning provide recommendations on how your actions could be either adopted, that what you did was right, or how different actions could take place, and maybe develop, task force to assess this kind of situations, communicate how to evaluate the implementation plan for the possible cause of action. So all these things are possible. Now, I'm not saying that every report will have equal value and length in all these 5 elements, but all 5 elements need to be present for the report to meet the requirements that the medical profession has for their critical incident reports. And that's why we want to establish the same requirements. Yes, of course, there will be a PowerPoint of this presentation. I know by this time, everybody's like, okay, I need a drink, I need to go eat, I need to go sleep. So getting there, guys, getting there. And yes, there will be the PowerPoint, the whole, since it's a project, there'll be a whole website dedicated to it that also all this information. Now, let me give you an example. A talked long, let's talk some practical specific things. So these are color-coded kind of form for the critical incident report, and that's what the online form will look like. Similar, I mean, not replicating it exactly, but similar to that. And when you start with describing the incident, there are two forces that will drive you. One is, as I already said, to be specific, because the more specific you are, the easier it is to find the solution. You take all the complexity into account, but confidentiality of what happened is ultimately a very strong force in our profession, right? So when we consider relation of confidentiality to writing a critical incident report, remember that HIPAA rules apply, right? So, and that pretty much means that when you write those, do not put any names of patients, providers, facility. Now, on the report, we'll see your name and email address, but it will never be published on the website. It will be only in, confirmation of the communication that you've submitted it, and I'll tell you why we need your name for that. But it will be it'll be separated after the form is submitted, before it appears in the repository. Now, provide only relevant information about the patient, providers, facility, and yourself. Relevant in terms of discussing the critical incident itself and making recommendations. You may also blur some information to some extent in order to preserve confidentiality. So what's relevant? Let me give you examples. First, we start with demographics. When you're writing a situation, I need to think of all three parties. I mean, there may be more people, right? But ultimately, there are three sides: patient, provider, interpreter. So is the age of patient important? Is the age of provider important? Is your own age important? Gender, marital status, educational level, employment status. If it is a mental health setting and an unemployed person is doing something differently than employed person necessarily. Or if you are a freelancer, and not a staff interpreter, obviously there will be, different levels of knowledge of the facility rules. So all these things may be important in certain scenarios and not so important in other scenarios. As far as an example of blurring, let's say you had a situation when there was a 3-year-old boy. Well, to further blur it and make it more neutral, you can make it a 4-year-old boy. But if you just say a child, in my mind, a child is someone between 0 months to about 16 years of age. I'm from Russia, just so you know why I stop at 16. I think after that, they're all adults. But anyway, at least I felt like an adult when I was 16. But so it's important that, if for a situation it's important to know the age of the patient or the gender, that was a boy, not a girl, right? All these things, you blurred one, so already you changed and you are not violating the HIPAA agreement by disclosing personal identifiable information. Now, assess the relevance of the needed cultural information. And here you would be looking obviously at language. Is it important to say that you're a Spanish interpreter or Russian interpreter, or is it not important? How typical is the situation? Does it matter, right? Place of origin. I put place of origin because it could be country of origin, but it could also be a specific city that's important. It could be a specific region. So, or maybe you could blur, and instead of saying, you're not a provider asking for an interpreter, you could say, instead of Chinese, you can say Asian, right? Patient. If you need to ask to know the kind of area of the world, but you don't care what language or what country, well, you can say that, right? You're not ordering a Cantonese interpreter for that patient. You're just describing the situation. Religion, is it important or not? Immigration status, familiarity with the culture of the other party. And that depends on who you're describing. If it may be important to mention that the nurse for the first time was interacting with the patient from this blah, 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 country, religion, language, right? Or the patient is only here as a, tourist here 3 days and blah, blah, blah. So this familiarity level with the US culture or the other way or your own, right? It's the first time I'm interpreting for the person who speaks Spanish who is from Chile, right? So that, again, could be an important part of the situation. A blurring example could be, instead of saying an interpreter is from Spain, patient is from Mexico, you can say in the report, the interpreter and patient share the same language, but are from different countries. Or share Spanish as the language, but from different countries. I mean, if Spanish is important for you, because it's, of some other things in that situation. So you're the one who are writing the report. You need to identify what's important information and how to preserve confidentiality. Then you need to assess relevance of the needed medical information. Do you need to share what specialty it was, conditions, stage of treatment, prognosis, right? Relevance of information about facility and appointment, type of facility, hospital, public health, private doctor's office, dental office, eye exam at Walmart. Urban or rural may be important. Level or type of provider, meaning like was it a resident or maybe if it was a technician. I mean, the different versions of who the provider is may be important. Type and order of appointment. Type is like checkup, follow-up, treatment. Treatment, is it like the first chemo or the last chemo, right? All those may be important. Interpreting modality. Was it face-to-face, video, phone? And existence of special protocols in that facility or in, like, again, if it's a psychic ward, if it's interpreting for an inmate in a jail health facility. So all these things may be important. Then assess relevance of the needed interpreter's information, something about you, right? What's your affiliation with the facility? Are you staff or freelancer? How familiar you are with the subject matter, with the patient, like maybe you've been interpreting for the patient and their family for the last 10 years, right? Versus seeing them for the first time. And then familiarity with provider and facility. I'm a human being. I'm like you. When I interpreted, I had my favorite doctors and my not so favorite doctors. So, and that affected, I'm sure, my decisions and how often different incidents happen. So all that may be important. So when you're writing those incident descriptions, you pick up from this kind of, matrix, like, okay, this is what I'll say, and that's not important. So you assess the relevance and share only what's needed. An example, let's say somebody submits this as the context of the incident. Interpreting for a child and his mother at the appointment to establish care with a new doctor. Well, not good enough, right? Because a child, as I said, in my mind, it could be 15-year-old. So if you already know your situation well, this probably will be a better fit for what you would say. The nurse asked if, sorry, not to what I said, continuing describing, right, the situation. The nurse asked if there were any known diseases or medical conditions among the child's blood relatives. The patient's mother responded that there were not any. Because I know the family, I told the mother that it's important to tell the nurse about the lung tumor of her husband, and then I relayed this information to the nurse. And that's where the person stopped describing that situation. I already told you what I don't quite see filled in as far as the child. The word child is not specific enough. But then also looking at the actual details of the incident, why did the interpreter feel that they need to talk about the lung tumor, right? It's kind of not clear, like, why did you do that? If you're, especially if you're a certified interpreter, you told the, family, interpreted the question, you could have reminded the family it's important to share, and if the person doesn't share the information, that's it. You just continue with your interpreting work. Why did you relay the information? So for that reason, you need to give more context and more details about the situation. And that would, here is a version that would sound better. Interpreting, instead of in context that you saw first, how about saying, interpreting for a 4-year-old boy and his mother at the appointment to establish care with a new pediatrician. I have been interpreting for this family before, specifically the boy's father, who has been undergoing tests for a lung tumor. The wife accompanied the husband to the appointments, including to the biopsy one. So you know a lot, in other words, in this family, and that's why you're more vested, and that's why you feel more comfortable on having side conversations with that patient. So it's a little bit now more understandable for a observer, right, for us, for the audience to understand, like, why did you feel that desire to say something? While we know in the Code of Ethics it says that, the patient has the autonomy. Now, as far as the details of the incident, again, if you add something, some more specificity. For example, in reviewing the family medical history, the nurse asked if there were any known diseases or medical conditions among blood relatives. The patient's mother responded there were not any. I told the mother that it's important to tell the nurse about the lung tumor of her husband. Then I relayed this information to the nurse. The mother didn't say anything to me, but I felt she became distant. Now we kind of already understand, like, why is this critical for you? Because there was something that gave you that impression that you shouldn't have done it. And that something was probably the mother's look, right? They looked at you and you felt like, oops. And then, of course, you continued with your work. But there was that moment, and that's what triggered you to understand that there's something wrong that you did. So it's important that you honestly just explain to us what brought you to realizing that this is an incident and not just, that's what we should do. Now you need to describe thoughts and feelings and concerns, right? During the appointment, I thought, why is she not telling about the husband's tumor? Later that day, I started wondering if I shouldn't have said anything. A little bit more context again. During the appointment, I thought, why is she not telling about her husband's tumor? What if it is important? What if it is genetic? It was the first time I interpreted in pediatric. I felt exasperated. I also was tired. It was my last appointment for the day. Then after the mother became distant, I felt uneasy. Last night, I started wondering if I should have said anything. What if she wouldn't want me to interpret in the future? That's what I call honesty. So, because ultimately, you are also all this, that look from the mother and everything that you experienced in that moment, got you to this things. Oh my God, what if she says I'm a bad interpreter? What if I'll never interpret for her before, right? All these things is very, important to keep in mind. And if we go through the steps, I'm not going to, since we're coming to an end of the presentation, I'm not going to do it, but it's important to, you write your first draft and then you rewrite it. And then you start seeing different aspects that you haven't seen before. And then maybe then you'll answer your own question, what was wrong and what you should have done. So at the step of explaining the incident, you identify what was wrong. And here what we identify is that the Code of Ethics demands were not met, and there was a misunderstanding of the role, thinking that somehow you could speak for the patient instead of interpreting what the patient said. When you get to the level of assessing criticality, obviously this was no harm. It did occur, it reached the patient was there, she looked at you, but there was no harm done. Now, comparing. The stage of comparing, you go to the reference literature. In our case, it's the Code of Ethics and Standards of Practice by the National Council, CCHI, California Standards of Practice, and IMIA Standards of Practice. So those are your main primary sources, and there you would look for specific paragraphs that address interpreter role. You need to know search words, right? They're PDF documents. Do the search words. Interpreter role, when to intervene, impartiality and autonomy, advocacy. And confidentiality, of course, because again, that's information that you gained about lung tumor was not at this appointment, it was at the previous appointment. And when you start reading the paragraphs in those documents about things, you will find all these paragraphs that clarify different things. And you will see that the difference between putting somebody's life in danger when you can share information and when there is no life in danger, what you do. They're two different things. Then you start clarifying to yourself what kind of factors increased it, right? And in this case, if we look at all these possible factors that could aggravate the situation, we really see that on the personal level, there are two. Unfamiliar environment, the first time I interpret for pediatrics, yeah, you probably won't know how important that is to know on that appointment, and your fatigue. It was the last appointment of the day. Organizational, possibly. We don't have enough information to know if this person talked to the supervisor, if they were trained. We don't know all that stuff. Why, they didn't catch that moment and did the incorrect action. And then profession level, maybe in our code of ethics, we need to describe a little bit more of what to do when it is not really endangering patient's life at that moment. How do we disclose that information or not disclose, and why? Maybe we need more examples. And so hopefully that critical incidents repository will help us with that. You can also go and reflect on what type of error it was. In this case, it was a mistake, right? And then, of course, possible actions. Possible actions will be consult with a supervisor. In a similar situation in the future, transparently remind the patient that it may be important and then leave it up to the patient. Focus on the current appointment. Don't think about the whole history of the interpreting for that patient. And impact of the profession. Ask, maybe somebody could write an article about that. So all in all, that report will be something like this. And you can see I didn't put too small of fonts here, so I fit it all on one page. In other words, again, it's not Tolstoy or Dostoevsky novel. It's and it's not even like Lord of the Rings or Harry Potter. It's a short version of what happened to you. Now, what next and why now? I'm sorry, we're getting to the most important part. It's not going to be long, but I ask you to hang in for about maybe 5 more minutes, and then we'll be going about our lives. So what we propose at CCHI is this, as I was mentioning before, is the creation of the Critical Incidents Report repository. And there, interpreters will submit these reports via online form that will be hosted on our webpage. The webpage will be called, Interpreter Rounds, and it will be available up and running by end of next week, by August 20th. If the report meet all the criteria, in other words, they have all those 5 elements, they have the sources quoted, and there will be, again, a document, PDF document explaining all these criteria, and there'll be a sample report that we discussed today available on the website. If they meet the criteria, they will be published on that website for everybody to look, think, reflect. And persons who submit such a report and which is published on the website qualifies for a non-instructional continuing education activity in the category research and publication. What the commissioners will make a decision about, which will be also ready by the end of next week, is how many continuing education units you will get for it. My gut feeling says, don't think it will be like 20. I'm just serious. Probably 1. But, sometimes, you're at the stage in your profession when rather than attending another webinar, you may want to create this report and have that one self-reflective type of learning occur to you. And you will get your 1 unit of continuing education. But we will announce the exact number. Again, it's just me speaking that, don't hold me to that words. The commissioners will have to make that decision. Now, based on those reports, we will hold virtual interpreter rounds. We'll have different panels of experts from the field. We'll try to have a diverse panel, let's say, interpreter trainer, a manager, and an interpreter. We'll hold this 2-3 times a year. I know we all want to have it every week, right? I'm kidding you, but then These will be recorded. This will be available afterwards for a review. This panel will select the up to five report, incidents for each discussion, and then, we will have this, as a profession, we'll have this repository both of critical incident reports, discussions by the professionals, so that then researchers could write further articles about it, and also you could learn through these mechanisms. In the PowerPoint that will be published on that website, you'll see that suggested reading and quotes that went into creating this presentation. There's some interesting things like Mindset, that book. I love that book by Carol Dweck, and then Better by Mistakes. Learning by mistakes is the hardest way, but it's the best way sometimes. As far as the panels, I see a couple of questions where there will be any language-based panels. I'm depending on which kind of reports we will receive, right? Because I'm not naive. I don't expect that that within a week we'll get 100 reports, that all 100 will be highest quality, ready for discussion. But if we'll see that there are some language-specific incidents or challenges experienced, then of course we would get that panel to be language specific to discuss it. It could be, so I'm saying language, but it could also of course be culture specific. So we may need to have a panel on specific cultures, but the discussions will be English and the other languages, so that other interpreters could learn from it. Because working with interpreters of different languages, I realize how sometimes, let's say, Korean or Nepali interpreters think that this is the only thing that happens only in their culture, and then I hear the same thing happening with Spanish interpreters, Arabic interpreters, and Chinese interpreters. But of course, there are specific situations that are typical just for those cultures too. So with that, I want to thank you for your time and for your participation. I did do some multitasking and looked at the questions and comments, but I will review them afterwards in more detail. And we will be now